would like to, we have a small enough group right now that if you wanted to pop into the chat and tell me who you are, maybe what your job role is, that would be helpful for me to have an idea of who's going to be interacting today. I've been working I worked in a syringe service program for about 7 years. And in 2013, I started doing contracting and curriculum development with the National Harm Reduction Coalition. My area of expertise is actually in injection counseling, so safer injection counseling. I know, I'm as surprised as you are, that's a job title. So that was my area. So I helped develop curriculum around safer drug use, safer injecting and basic wound care, harm reduction support, post overdoses, things like that. So I was doing that through 2013 up until, well, about a year ago when I came on full time. I also have spent 3 years working in a behavioral health clinic. So a CCBHC, it's kind of similar to an FQHC. I was in the clinical training and innovation department there. My background is actually in clinical mental health counseling. So any day now, I'll be finishing up my license. But I do like to tell folks about me. I have a really diverse background. I did not come into this field, though, a believer in harm reduction. When I first started learning about harm reduction, I was in my master's program, and I remember there was an individual who came to talk to our class who was from the very syringe service program I ended up working at. And I remember sitting in the class, hearing what this person was saying about what harm reduction is and so forth, and just having all of these moral issues. This was in the early 2010s. And still having a lot of moral issues, having a lot of just general opposition that I couldn't quite put a finger on what my real problem was. And I was very grateful that I had a professor at the time who was willing to invest time with me to help me kind of sort through some of the things that were posing a barrier to me accepting this as a viable public health strategy, a compassionate way of working with clients, things like that. I tell you that because it's okay to change your mind. If you are somebody who's here who might be struggling, or you know somebody in your community, because we will talk about that, you know somebody in your community who is struggling getting, quote, on board with harm reduction, that doesn't mean that those individuals are not worth investing in. And I just encourage everybody as we go through the presentation today, open hearts, open minds, things like that. But that's a little bit about me. Does anyone have any questions before we go further? No? Okay. All right. So, oh my goodness, several substance abuse clinicians, fantastic. Oh, wonderful. Okay. The other thing too is, again, because we have a smaller group, please utilize the chat. I will do my best to kind of keep tabs on it. If I ask questions, feel free to unmute yourself at any point and answer. If you want to engage through the chat, that's fine as well. And if you do have questions, stop me. Just unmute yourself and ask the question. I would much rather have it be interactive this way than have folks feel like they have to wait until the very end of the presentation when you might have completely forgotten what you were going to ask, or it's taken out of the moment. So with that, let's get started. If you ever want to get a hold of me, the best way to do it is through email. So that's me, curryizzo@harmreduction.org. And if you do want to know more about the Harm Reduction Coalition, the website is just simply harmreduction.org. How many of you are, you can use the emojis, or you can just kind of raise your hand, you can pop it into the chat. How many of you are familiar with the National Harm Reduction Coalition? Anybody, a couple people? We've been around for a really long time. So we were actually formerly the Harm Reduction Working Group that started in about 1992. Some of our key members were Dan Bigg, who we have to thank for community-based naloxone programs from Chicago Recovery Alliance. Dave Purchase, who's kind of considered to be the godfather of syringe exchange programs, who is based out of Washington State. Edith Springer, who wrote what's considered to be kind of the first American article establishing the evidence base for harm reduction. And also Amani Woods, who was key in uplifting Black voices in the harm reduction community, also in Washington State. So those were some of our key harm reduction working group members. I've kind of affectionately come to call the NHRC kind of the mothership of all things harm reduction. So a lot of different kind of offshoots have happened around the country, and it's incredible and beautiful to see. We are really fortunate that we have an incredibly diverse group of employees with many different life experiences and so on and expertise. So if you are interested in, let's say you are a state that is trying to get an amendment to a law, or you're trying to set up a syringe service program, anything like that, we have specialists on our staff that assist with policy and advocacy. We also, we just had one in San Juan, Puerto Rico. We will probably not be doing it for another 2 years. So we're a little off because COVID made everything a little strange. But we have our national conferences. If you ever get a chance to go, I just can't recommend it enough. It's an incredible experience. We do our training and technical assistance. That's how I am coming to you today. We do a lot with overdose prevention, getting programs throughout the country set up with their own OOPs. And we also have a wide range of different resources and publications. If at any point I'm referencing something and you say, oh my gosh, I would love to know more about that, or where did you get that from? Please just shoot me an email and I'm happy to send anything your way. You can also submit a request through our website. And we also have a ton of just general resources on our website as well. Okay, what we can expect from our time together. We're going to talk about what harm reduction is, what it's not. We're going to talk about some of the different principles, look at harm reduction intersects, and then the second part of our time together will be spent looking at stigma, and then we'll wrap up, address any questions, concerns, things like that. All right, so here's where I would like you to get a little interactive. How would you define harm reduction without using the phrase meeting people where they're at? Not because it's a bad phrase, not because it's a bad phrase. I'm just curious, how would you define harm reduction? And how many bubbles did I just pop? Like, oh, you took it. Any brave souls out there? How would you define harm reduction? Oh, Todd, I see your hand. Yes. Oh,
I'm muted. I'm sorry about that.
No, they're good.
I would say options to abstinence models.
Yeah, absolutely. Yeah. Anybody else?
People are going to use, so let's make it safe for them.
Absolutely. Anybody else?
I was just going to say taking baby steps.
I love that. Yes. I don't know if anyone here is a fan of the movie What About Bob, but every time I hear Bob saying baby steps to do this, baby steps to avoid an abscess, baby steps to avoid hepatitis C. Yeah, absolutely. Oh, Spencer, you're speaking to my soul. Keeping people from dying. Supporting individuals to make informed decisions. Yes, education is such a huge part of harm reduction. It really is. And one of the things we're going to talk about a lot throughout this is when it comes to harm reduction, if you identify as this way, and I'm not saying you have to, if you identify as that capital H, capital R harm reductionist, we do not inflate risk and we don't downplay it either. And I often tell people it's right in the name. It's harm reduction. It's not harm, obliteration. It's not anything like that. We acknowledge that real harms do exist. So we utilize what education we have and what resources we have and we know to be true today. And that's what we use to help other people make informed decisions for themselves. And I say what we know to be true today because information is constantly evolving and changing. And if there's anyone here who has that background in public health or science or medicine or anything like that, you probably know not a great idea to get too tied down to one specific thought theory because things change. And it's great to have an open mind. My hope for you all by the end of today is that you will have your own operationalized definition for what harm reduction is. And sometimes people would ask me, well, okay, Shannon, how do you define harm reduction? And I often give a non-answer and I'd say, well, it often depends on who I'm speaking to. So if I'm speaking to a public health official, if I'm speaking to law enforcement, if I'm speaking to one of the participants at the syringe exchange program, if I'm speaking to a fellow therapist, if I'm speaking to whomever it is, it might slightly change depending on where you, the person who's receiving the information, where I'm assessing you're at in terms of receiving the information. So don't be afraid to get flexible. We do have definitions we're going to go through. And also harm reduction, the definition doesn't really belong to any one singular person or institution. And with regard to using the phrase meeting people where they're at, it's not a bad phrase. It's a great phrase. The reason I encourage people to kind of think outside of that is, does anyone want to take a guess why? Why did I bust everyone's bubble? Oh, Todd, did you? Yeah.
Dignity of risk.
Did you read my slides, Todd?
No.
Nobody ever mentions that. We're going to have to talk later. Nobody ever knows that phrase. That's going to come up. Why specifically this phrase, though, am I encouraging people to think outside of?
It's also like social work 101. And I would say not all social workers are steeped in harm reduction principles.
Yeah, that's part of it. That's part of it. Anyone else want to take a guess? Oh, yes, there's so much more than just meeting people where they're at. Yep, that's true. The other thing too is when it comes to the phrase meeting people where they're at, years ago, when I first started doing these trainings, one of the first things I would do is I would open up, and part of the introduction was I would ask people, how do you define harm reduction? And they didn't have this little caveat there. So I'd ask people, how do you define harm reduction? And overwhelmingly, people would say, well, meeting people where they're at, meeting people where they're at, meeting people where they're at, meeting people where they're at. And I started to lean into it a little bit more. And one day I asked somebody, I said, well, what does that mean? And they said, well, you're meeting them where they're at. I said, yeah, I got that. Yeah. What does that actually mean though? And they said, well, wherever they are, you're going to meet them there. And so I've learned to have, I have a very expressive face. I've learned to have a good poker face, but internally I'm thinking changing the order of the words doesn't change the message. A for effort. What I started to notice though was in the past decade or so, and you probably have seen this too. In the past decade, harm reduction is getting a little bit of a PR boost. People are having permission in some institutions to actually say the term harm reduction. I know in New York State, even though we are fairly harm reduction oriented, if you were working in a clinic, you really couldn't use this term up until about 5-6 years ago. So as professionals in the institutions have become more comfortable talking about harm reduction, what has happened is the actual philosophy behind it seems to be getting a little lost. And it seems to be kind of sanitized down to this singular phrase, where I would start hearing this phrase repeated by people who are clearly not practicing harm reduction. So that's what I'm going to encourage you to do, is to kind of think about how you personally conceptualize harm reduction, how you talk about it with different people. Meeting the people where they're at is not a bad phrase. We sometimes will add in there and not leaving them there, because harm reduction is not just about meeting you, it's about walking alongside you. I always tell people I never push people from behind. I never pull them from in front. I walk next to them. They speed up, I speed up. They slow down, I slow down, and maybe ask a few questions about what's going on. So let's move on, because there are some definitions that we're going to look at. Before that though, harm reduction has a really interesting, beautiful, rich history, community, and culture that is entrenched and inextricable from the drug using community. People who use drugs, people who engage in sex work, those individuals are the ones who gave us this movement. And it is kind of my personal commitment to educating others. I want to make sure that that community, culture, and history is preserved in some way, shape, or form, because we don't want to leave the voices. We don't want to leave behind the voices of the very people who sacrificed and figured these things out. I'm going to have you watch this short video that the National Harm Reduction Coalition put together, and it's all featuring people who are deeply entrenched in this movement, who self-identify, who have loved ones, and so forth. What harm reduction really means to them, so you can have a better idea and understanding of how this can be conceptualized in many different ways.
Right. Personally, for me, harm reduction is important because I watched my brother use drugs for years and ultimately overdose and die.
Harm reduction is important to me because it means keeping my family safe.
I believe that it also includes therapeutic rather than punitive drug policies.
I have a lot of family drug use, and it was constant fights, bitterness, anger.
I was lucky enough to make it when I had some times of struggle. In my world, I believe to change someone else's life is to change their narrative.
And with harm reduction, I've learned not to have all that anger, to be more compassionate, to not judge anybody and be so critical.
Harm reduction gave me a sense of family, sense of belonging, a place where I was accepted just as I was, just as I am.
As a physician, I believe in harm reduction because I'm sick and tired of my patients having to die.
I lost my daughter to the disease of addiction.
May all beings be free, and may my work contribute to that freedom.
It's important for you to find your own healing, to find your own path.
It's about civil rights. It's about public health.
Helping people regardless of the choices they make in life.
We don't judge people.
I believe that the people themselves are the experts on their own lives.
My harm reduction truth is that I was a skeptic, and even as a person who injected drugs.
I believe that harm reduction is a movement that is never going to stop.
That advocates for human rights, that advocates for humanity, that advocates for being a whole human being and respect.
Harm reduction works because it was created for and by people who use drugs.
It's not a radical idea. None of these concepts that people are complaining about, I think, are radical. They're life-saving, common sense things.
I believe that harm reduction is the absolute opposite of tough love.
Reduction
asks us to look at people as full human beings and recognize their full humanity. And that is challenging because we live within systems and structures that every day require us to do the contrary, to stigmatize and to dehumanize people. When I was looking to build a relationship with my father, there were so many people who told me to forget about it, to wait. And for me, I lost the opportunity.
My boy Kenny, he was only 25 years old, died of an overdose. He was a peer educator just like me.
The truth about harm reduction is that the bigger our movement grows, we run the risk of losing the essence of harm reduction.
My truth about harm reduction is that it is the answer to most of life's problems. The hard part about having that skill and knowing that that's true is actually doing it.
I believe that people really do want to be healthy and well. I believe the war on drugs is a war on people.
Harm reduction has helped me reunite with my family and most importantly with myself. Harm reduction is part of my life. Harm reduction saved me.
I believe harm reduction is just another way of saying that I care about you.
In my mind, harm reduction is the real thing, and that is love. And that's what I try to do each time I step on the street, to deal in love and safety.
I feel like our community has been so stigmatized and pushed down and pushed out and pushed away that people forget that we're not even just like them, we are them. We are people. We are your neighbor, we are your son, we are your friend from college.
Harm reduction is rehumanizing. Harm reduction is love. Harm reduction is kindness. Harm reduction is helping. Harm reduction isn't about me. It's not just about you. It's about us.
How you doing today?
Any thoughts, reflections? So the one person who identified as a physician, that's Dr. Kim Soo. Dr. Sue recently left us to go be a professor at Princeton, as one does. So she's doing well, teaching a course in addiction medicine. But she also wrote a book called Getting Wrecked, and it's looking at women in the carceral system. I have been doing trainings for years, and I've never had an emotional reaction in a training except for the first time I had to do one on carceral pregnancy. I actually had to stop because it was so emotional and so hard, the material. If you don't have a great knowledge base for the experience of people who are in carceral systems, particularly mothers and pregnant individuals, definitely get that book. It's worth it. You might cry though, you've been warned. So let's talk about what harm reduction is, because we do have some set definitions. Where did these definitions come from? They did not come from SAMHSA. They did not come from the CDC. They did not come from NIDA. They did not come from the National Institute of Health. They did not come from any of those institutions. These principles were actually adopted by the Harm Reduction Working Group based on the work that was happening at Merseyside over in the UK in the early 90s, late 80s. Harm reduction, the movement as we know it kind of today, because different forms of harm reduction have been around for millennia, quite honestly. And as we go through this, you'll be able to start to draw some parallels. But the harm reduction movement we know is it today to be really kind of started to gain traction in the 70s in the Netherlands, because of a group of individuals who formed what is kind of considered to be the first unionized group of drug users. They called themselves the Junkie Bund. And the outcomes that were happening in the Netherlands with regards to increased treatment referrals, decrease in crime, decrease in infectious diseases, and especially when a lot of the world was getting hit hard with the HIV/AIDS crisis, they were doing okay. So there was a researcher, Professor Jerry Stimson, who some of you might know. He actually went to go study what was happening, wrote the first article that established kind of the first evidence base around the benefits of syringe service programs in 1988. He was so engaged with harm reduction and how well it worked. He actually went on to become a co-editor of the International Journal of Drug Policy, and he was a co-founder of Harm Reduction International, which is our sister agency. He is still around. He does some really great work with harm reduction for smoking cessation. So if you may have any interest in that, check out Professor Jerry Stimson. So in the UK, as a kind of a direct result of what they were learning based on the work in the Netherlands, Merseyside was set up. And Merseyside was kind of the template for our programs as we kind of knew them to be. So these were the principles that the Harm Reduction Working Group and Merseyside collectively came together and put together. It is a set of practical public health strategies. When it comes to harm reduction, we're going to look at this a little bit more down the road. Harm reduction and abstinence can absolutely coexist. They can be congruent goals, 100%. The whole point of it is to offer people a range of options. That might be just being safer in their use. It might be managing the use of one substance and reducing the use of another, or being abstinent from another. It could be a whole bunch of different combinations. It also exists to respond to those disproportionate rates of infectious disease, specifically HIV, hepatitis C, STIs, skin and soft tissue infections. So we see that the more we implement harm reduction strategies and we have options for people to have safer injection practices, we see a lot of these infectious disease rates go down. Most importantly, though, harm reduction meets, accepts, and engages people who use drugs, that acronym right there, PWUD, people who use drugs on their own terms, largely because they're the ones who gave us this movement. Harm reduction can be conceptualized in two different ways, though. So we have our little h, little r, and this is really just a behavior. So for example, I bite my nails. I know. In the time of COVID, not great, right? I'm not always washing my hands before I bite my nails. I'm not always conscious of it. And when I bite my nails, sometimes I hurt my skin. So that leaves me vulnerable to infection, right? It leaves me vulnerable to bacteria and so forth. So one of the things that I tried to do was, well, what if I stopped biting one nail, one finger? What if I stopped biting two? What if I stopped biting three? And I'm actually doing pretty good. I'm on 3 right now. And as long as I don't see an uptick in severity on the other fingers, that's a simple act of harm reduction. there's no greater philosophy behind it. There's nothing more meaningful behind it. It's simply, I don't really want to get an infection and it hurts, and I'd like to stop that. Harm reduction, though, with the little h, little r, this is sometimes what I see agencies doing, though. They're engaging in this, meeting people where they're at without the larger philosophy behind it. So they might say, well, we're a harm reduction agency, or we practice harm reduction because we let people smoke cannabis and we're not discharging them for that. Or we give out naloxone, so we're a harm reduction agency. Meanwhile, they still have very punitive policies. There's no voice, there's no advisory panel by people who are actually being affected by these different policies and programs. And we're going to talk about that more in principles. But little h, little r, that's a step, but that's not really what this movement is about. It's about incorporating the philosophy as well. So that is rooted in activism, and it's rooted in a very deep respect for people who engage in some of these practices that have historically been considered morally wrong, criminal, things like that. Often this is because of our societal's perception that that person has been a failure or whatever the case may be. And it's usually because there's a lack of resource or other types of factors that we haven't taken into consideration. It also acknowledges people from these communities as folks who can and absolutely have made deeply meaningful contributions to public health and wellness. Deeply, deeply meaningful contributions. Dan Bigg was an individual who used substances. The whole reason why we have community-based overdose prevention programs is because of the work that he did. Same with Dave Purchase. We have a whole bunch of folks who are still doing things underground, gray legal, so not necessarily legal, but the cops are leaving it alone, that kind of thing, who are doing it every single day because it's just the right thing to do, and somebody has to do it, and somebody has to look out for people in the community. So if nobody else, who will do it? And it's usually the people in those communities who say, well, we're going to have to take care of ourselves. This is an article, just an excerpt. I know it's a lot of text, but I'd really like to just focus on the piece here that is bolded. This was from an article that our former executive director, Alan Clear, had written, excuse me, for the Huffington Post. And he details, it's a two-part thing. You can Google it, it'll come right up if you go to Alan Clear in Huffington Post. And it's Harm Reduction in the United States, Whose History. And throughout this, he talks about how he had been approached to write an article narrating the history of harm reduction by various journals, and he had been rejected. And some of the feedback, he said, okay, I'm not an academic writer. Some of my language, okay, probably could have done this, probably couldn't have done that. But some of it was a little personal, and some of it was very much, I don't know that you're qualified to be able to speak on this. And one of the things he really speaks about in these articles is, if I can't talk about my own community, who can? Are we going to leave this to researchers? Are we going to leave this to people who have never interacted in a real meaningful way with the drug using community or the sex work community or anything like that? Are we going to leave our story to those individuals? Because if we do, we really run the risk of losing our history. We run the risk of losing our roots and having our entire movement whitewashed. So that is kind of what Monique Tula, who was the individual in the video who was talking about. We are running the risk of losing our movement and our history. The more these programs become popular and more commonplace, that's great, that's wonderful. And there is a disturbing trend of shutting out the voices and participation of people in these communities. We're going to talk about that more in Stigma. So here we go. My friend Todd, dignity of risk. So philosophy and practice, right? As a philosophy, harm reduction, it's really asking you to acknowledge that human beings, we do things for different reasons. All of us engage in some kind of risky behavior, and we have our own complex, rich, confusing, logical, illogical, whatever it may be, reasons for doing so. But we all engage in these types of behaviors to different degrees. I might not make the same choice for myself as somebody else. I might not want my children to make those same decisions, but that doesn't take away from the fact that that individual has dignity of risk. People, as autonomous human beings, they have the right to do things that maybe I or you don't necessarily agree with. Harm reduction also fills in that gap between when somebody is willing to make a change and when their circumstances allow for it, because those two things, trying to get those things to line up can be waiting for the stars to align. It can be really, really tricky. Somebody might be very motivated to make a change. Maybe this is an individual who says, you know what, I have tried everything under the sun to try and not use drugs anymore. I think I need to go away. I need to go away to an inpatient facility. I need to be away from the people, places, and things. I just need to get away. Great. Who's going to watch their children? What's going to happen to their home? Maybe they're a primary caregiver for another family member. So they're willing, and yet the circumstances don't allow. On the opposite side of that, you might have somebody who is wrapped up in the court system, and one could argue the circumstances absolutely allow for that. And yet this might be somebody who's saying, you know what, I've gone down this path several times. It never seems to work. And I'm tired. I don't want you to keep telling me what to do. So they're not willing. And we know that change kind of needs meaningful change, sustainable change kind of needs those two things. The circumstances have to allow for it, and the person has to be willing of their own volition. And to kind of segue into harm reduction, it really just empowers you as providers, as allies, however you want to conceptualize yourself, to look at these different types of behaviors through a much more humane and compassionate lens. I used to have a lot of confusion over when I first started working in the syringe exchange program. I was doing counseling and so forth for some of the folks, and I had a really hard time understanding why some of my peers in the program were having such early burnout in different agencies. And then I switched to an agency setting and I thought, oh my gosh, this is really, so you're on a time crunch. You have to see X amount of people. You have to deal with paperwork. Like, this is a lot. So I could see, and I had a greater amount of empathy for the people in my own program who were stuck in some of these systems that they didn't necessarily want to be stuck in, but hey, billing and insurance, am I right? Harm reduction, though, being able to practice that authentically really did allow me so much more latitude to be able to work with people on a humane and compassionate playing field. It's that bridge between willingness and ability. It's very much kind of that in the meantime. I don't want to say I've met every single person who uses substances. I've met a lot. I've never seen this happen. Maybe it has. I don't know. I personally have never seen somebody go from very chaotic substance use to saying, I think I want to stop. And then they wake up the next day and poof, it's done. They're good forever. They're fine with no intervention, no needed support. I personally have never seen that. So when we say, and Tom, you had put in here too, you know, dead people don't recover. Harm reduction gives people that in the meantime to get from where they are currently to the goal that they want to accomplish. No matter how big that goal is, no matter how unattainable it might seem in that moment, harm reduction exists to keep that person engaged, to keep that person safe, to keep that person alive so that they can continue that track. Once again, with the harm reduction approach, it has a whole bunch of different ways you can do this. So we have our safer techniques. This might be somebody who has said, nope, I want nothing to do with stopping my drug use. I'm going to continue to go and I'm going to continue to go hard. And at the same time, this is somebody who might be reusing a syringe over and over and over again. We know that that dulls the tip. It leaves people very vulnerable to scarring, skin and soft tissue infections, all sorts of different things. So what we might do is in that case say, okay, your goal, you don't want to stop. That said, maybe we can reduce some of the damage that's being caused to your arms by, can we give you more syringes so that you don't have to reuse? Can we sit down and talk about your ritual or talk about some of the reasons why you might feel like you have to reuse? And then we'll give you some safer options. Managed use might be, you know what, I don't want to go this hard. I want to bring it down a little bit. How do I kind of do that? And that might be the step down, the baby steps. So maybe instead of using 5 times a day, we try and work towards 4 and then 3 and so forth. And then of course there's abstinence. And again, I can't say it enough. If somebody comes to me and they say, my goal is to be off of everything. I want abstinence only. I want to be in a 12-step. I want nothing to do with any of the medication. Their goal is now my goal. And I will do everything under the sun that I can to try and help get them to that point. Abstinence, though, can be a little tricky. Because again, people don't typically go from chaotic, high-risk substance use right into abstinence. So having that person who can work with whomever is seeking services, but have them truly and honestly walk side by side with them instead of pushing them faster or kind of slowing down based on our own kind of thoughts and assessments, but really letting that person drive the interactions. That is going to be the best way you can get somebody to meet that goal of abstinence. We talked a little bit about what harm reduction is. Let's talk about what it's not. So first and foremost, it is not the reason why there are so many overdoses or why there's so many people who are using drugs. In fact, when it comes to Narcan, naloxone, it's been around forever. I mean, naloxone as a medication, I know that there's a couple medical providers on here. I believe it was actually released in 1965. Jack Fishman, who is one of the inventors of it, who is also instrumental in the discovery of endorphins, your endogenous morphine. His stepdaughter is on our board now, which is really interesting and really fantastic. We know that naloxone's been around for a really long time. Dan Baig's program that he piloted in the early 2000s, I mean, that's almost over 20 years ago at this point. What typically tends to happen is people being people sometimes conflate correlation with causation. So they'll see a lot of different overdoses, or they'll see programs popping up and they'll say, well, that must be why all of a sudden we're starting to see an uptick in these different these fatalities and so forth. When the reality is harm reduction programs often take a really long time to set up. And by the time that they do get pushed through in emergency situations, it's responding to an epidemic. We can look at what happened with Indiana. So it was historically very resistant to syringe service programs. And then once the HIV outbreak happened, they were still very resistant, finally implemented, curbed the crisis a little bit. And there has still been a very contentious, difficult relationship with the state and syringe service programs now that they've kind of gotten a hold of it. It's also not the reason why there's so many needles on the street. There have actually been a lot of different studies that show that places who have a syringe service program and harm reduction programs, people are much more likely to use syringes to those programs. In fact, the more syringes that people are given, the more likely they are to return them. I can tell you, I've seen this in real time. This is a true story. The person who I'm going to reference knows that I tell this story. They think it's pretty funny. The first time I met them, they were injecting about half an ounce of cocaine a day. It was about 30 injections. That's not talking about punctures. That's just, we're talking injections. I don't think I can fathom how many punctures considering the state of what their arms looked like. So when this person first met me, their goal was not to stop, not to reduce. It was, I'm going hard. I just need help finding a new place to go. So I said, okay. So we had a little conversation about some safer options. And finally I asked, can I give you some syringes to take back with you? And they said, yeah, I'll take a 10-pack. So I did the math real quick in my head and I said, well, can I give you more? And they said, you can give me more? And I said, well, can you bring them back? And they said, yeah, okay. And I said, so what have you been doing with the other syringes that we've been giving you? And they said, well, I throw them out. Now they were living at a motel at the time. So I said, okay, so you're throwing them out. Can you tell me a little bit more about that? How do you do that? And they said, well, I just throw them out. And I said, well, here's why I really don't think that's a great idea. We don't want accidentally housekeeping to go and pick up the garbage, right? And accidentally stick themselves. And it genuinely never occurred to that person. It genuinely never occurred to them. And had a really interesting conversation about the different types of bacteria and different types of viruses that can be transmitted. And long story short, this person had started taking boxes of syringes with them to the motel. They were starting to be kind of an unofficial peer, and they were setting up all the other folks that were using in that motel with new syringes and bringing them back. So initially they had some concerns about, well, I don't want to be taking a giant red container everywhere, the Sharps container. And I said, well, I get that. You don't want to be walking on the street. Nothing says, hey, I have syringes more than a giant biohazard, thing. So I had a thing of protein powder on my desk. And I said, if I give you this, will you take this and put the syringes in? And they said, okay, sure. So I dumped out the powder into the Sharps container, gave them my protein thing. They came back the next day with it. and became more and more kind of comfortable bringing stuff back, and eventually did start taking the sharps containers, the giant ones. They would bring back everything. It was shocking to me. Then they started taking naloxone and they were passing it out to everyone. In fact, I remember them sitting at the desk one day with me, and they were just kind of having a general conversation. And somebody came in, and I was doing an exchange, and I said, "Hey, do you have anything to drop off?" And they said, "Nah, not today." And this person starts to lay into them. Very colorful language. I said, "I don't know that we need to go that hard." And they're like, "Don't you know what can happen? Haven't you ever thought about that? What are you doing with it? You just throwing them out? You just throwing them out?" And I start laughing to myself, and I said, "Wow, we've come a long way in a month." But this person, who had historically been engaging in some very high risk behaviors, putting the community at some significant risk, was now the kind of only person we had going into this one pocket that had drug use on a level we never knew was occurring. But because this was their community, now they were starting to take care of them. It was a really incredible thing. And because we had built up trust, now people would come in and say, "Yeah, BC told me to come see you. BC told me to come see you." And I say, "Okay," because referral is the best, word of mouth, and it works. It works. So I tell you that because I can see how it would seem counterintuitive to some folks to see, well, if I give you more, how does that reduce the amount on the street? But if you give people more, if you give them what they need, they're more motivated to come back and continue to take care of themselves and get what they need, because they're seeing in real time the benefits of it. Again, not making our communities more dangerous. We have extensive research to show that, in fact, places that have syringe service programs and harm reduction programs, the crime rates really don't do anything. They're often going to be in areas that are already hard hit with drug use or crime. So again, sometimes people tend to conflate correlation with causation. It's also not a way for people to avoid personal responsibility. I cannot tell you how much change I have seen in the 7 years working at the syringe program. It was small. It took a long time, but it was incredible, and it was sustainable, and it was meaningful. And to give you an idea, so with returning syringes, right? We had a lot of folks, and I'm based in Buffalo, so I think you know about our weather by now, especially in wintertime. I have seen so many people who were walking in snowstorms, walking with not great, definitely not recommended weather gear, just to return syringes and make sure that they had new ones to take back, to take care of themselves. These individuals easily could have just thrown them out in a bin somewhere, but they didn't. They made a choice. They made a choice to come and engage with these services. There's something to be said for that. There's a lot to be said for that. And the more people come in, the more we get to know them. The more we got to know them, the more we got to establish rapport. We got to reestablish trust. A lot of these folks have been institutionalized. They've been in different systems throughout their entire life. Not everybody, but a lot of them. A lot of them have been very traumatized by some of these different institutions that claim to want to help them. So giving them a positive experience was incredible. It was really incredible. And again, not keeping sick people sick. We know that syringe service programs in particular, I know I'm referencing syringe service programs a lot, and that's largely because that's kind of, when we talk about harm reduction, it's largely talking about syringe access as well. We do know, though, that a lot of syringe service programs do act as a hub. So when people go there, it's not just to get syringes, it's to get education, it's to get referrals, it might be to get some food, it might be to get some socialization, to get out of their own isolation, to get support from other individuals. It's also not restricted to naloxone and syringe service programs. So harm reduction, it's rooted in these things, but it's so much more than that. It's education on different types of prevention for infectious diseases. It's a safe disposal for sharps. It's case management services, all different types of referrals. That's what harm reduction really should be. It should be a ton of different options. And if you are an agency, maybe you are a clinic, you can still, and I know laws and policies and things like that, you might not always have a lot of room for flexibility. Know where in your community you can send people for these different things. You don't have to be an expert in everything, and your hands might be tied because of certain policies. That does not mean, though, that you can't give people referrals to other supports that could help them. All right, what does it look like in practice? I tried really hard to kind of give concrete examples of what this would actually look like outside of my own experience. But to be honest with you, harm reduction really comes down to how we're treating people. And I love this quote. I live by it. If you have never heard it, you're welcome. It's a really great reminder that at the end of the day, whether you're a medical provider, you're a therapist, you're a peer, you're a public health professional, whatever it may be. And I think we know also from health literacy and things like that, that often things that we say to people or we tell them to do, about half of that's forgotten. So people might forget what you said. They might forget what you did. People are not going to forget, though, how you made them feel. If you made them feel special, if you made them feel worthy of your time, if you made them feel like they were worth the investment, they will remember that. And that can carry people a really long way. The best information in the world does not matter if it's delivered with disdain, contempt, or shame. So let's talk about some of the principles, because harm reduction is upheld by principles, and we're going to go through these, and then I think we're going to take our break. First and foremost, we have our health and dignity, participant-centered. You're going to see the word participant a lot instead of client, consumer, or patient. That's because in the harm reduction world, we seek to dismantle those power differentials. So we often refer to the people that receive services from harm reductionists as, you gave us this movement. We are helping to facilitate an exchange of information. You are participating in our program. I just happen to have certain information, but you're going to give me information too, and we're going to work together. It's more of a collaboration. With health and dignity, shocking. It's treating people with dignity, compassion, and respect. But it's also looking at the quality of that person's life on an individual level and the community level. So that example I gave you earlier, the initials BC. So BC, their quality of life on an individual level was improved because with some getting new syringes, it was reducing scar tissue, it was reducing instances that they would have to share syringes, so rates of infectious disease, and also getting those other used sharps containers from around the motel and giving people new ones, making sure they were properly disposed of. That's a major community level intervention of harm reduction. It's also participant-centered, so we believe in non-judgmental and non-coercive services. So we very much believe that people will make the right decisions for themselves if you give them the resources, the tools, and the education to do so. Has anyone ever heard the saying, nothing about us without us is for us? It's a great one, right, Tom? Yeah, it's a good one. Nothing about us without us is for us. So participant involvement really asks that if you are providing services to people who use drugs, people who engage in sex work, any high-risk behaviors, it cannot be considered harm reduction unless you have the real voices of people being impacted by those policies and programs, if they don't have a real voice in the creation and how those different things are being implemented. And I've heard some pushback on this saying, well, you know, we're tied because of grants or we're tied because of this. It really doesn't matter, because at the end of the day, you can have an advisory board of people who might be utilizing these services. And if there are questions they have, well, why can't you do this? How come this happened? You have an opportunity to actually give them the information about why. And sometimes people, and oftentimes, those are the folks who are going to give you some of the most creative solutions. Or they might look at you and go, okay, that makes some sense. I don't like it. You don't like it. Nobody has to like it, but now I get it. And thank you for explaining it to me. Instead of having, you know, somebody at the front desk tell them, I don't know, it's just the way it is. Sorry. So please, 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 I beg of you, if you're going to have a program that is going to be considered harm reduction, you must have some sort of participant involvement. We also honor participant autonomy. So this acknowledges people who receive services, they are the primary agents of change. They are the ones that we can count on to disseminate the information that we're giving them. My voice is only going to go so far. And that example that I gave you earlier, because I had that one relationship with one person, that person was able to reach pockets of the city and populations that would never accept me in. It would never happen. So we have to acknowledge that if I'm going to give you information, it's in my best interest, it's in everybody's best interest, because you are the primary agent of change. You are the one that's going to be able to inspire others around you, because you will speak to all of your lived experiences. It also has deep roots in acknowledging sociocultural factors. So a big part of this is, and we're going to look at this in Harm Reduction Intersects, we have to recognize that there are many different reasons why people are vulnerable to drug-related, sex work-related, any type of related harms. And it often has to do with racism, classism, gender-based violence, trauma, all those different types of things. And if we ignore that, we cannot offer people the best strategies to help reduce whatever harm they're contending with. This is also kind of the part where I have to acknowledge, if you are one of the individuals who is kind of very motivated for harm reduction because of the opioid epidemic, we cannot forget that a lot of why we're starting to see the big acceptance of harm reduction has to do with painkillers and the opioid epidemic, which largely affected individuals who are white, who look like me. We cannot leave behind the people who have been disproportionately affected by racialized drug policies. Back in the 80s, entire communities were decimated because of mass incarceration. And many of those individuals are still suffering today with how our policies are disproportionately applied. I can't speak for the drug courts where you all are, but I did have one participant bring it to my attention once when I mentioned drug court. They said, "Oh, you mean white people court?" And I said, yeah. And the first time I went to court and I saw how people in regular drug court were versus people in opioid treatment court, it's very different, even in terms of being able to access treatment. I had one individual who was in their early 50s, a Black woman, engaging in some very high-risk crack use. Finally, after a couple of years of working with them, said, you know what, I think I actually want to go to treatment. And it was like, everybody stop what you're doing, stop what you're doing. We're going to make this happen. What do I have to do? Who do I have to call? What do I have to do? Because it was just so long in the making. Got a little too excited about that. So because I had gotten so excited about that and I kind of lost sight of some of the harm reduction principles there, we moved very quickly to try and get this person into a treatment facility, and they were there for 3 days. And when they came back, or when I saw them next, I said, oh my gosh, what happened? And they said, it took them a little while to talk about it. And they said, they told me I didn't belong there. And I was like, who told you? Who told you you didn't belong there? Who am I going to call? And of course, I'm like, I have my phone already. I'm like, I want names. I want times. When did this happen? It wasn't the staff. It was the people in their group. And she said it was a young white girl who looked at me and said, why are you here? And I said, well, I'm trying to get better, same as you. And she said, but my people are dying. And she goes, she said it was so much hatred. And she's like, I just don't want to stay there anymore. And she goes, and none of the staff understood. They were like defending her. And I'm like, was the staff all white? And she was like, yeah. So it's really tricky because racism is real. Historical harm, historical traumas are real. Representation matters. But I've always kind of thought about that. We have different medications for opioid use disorder. We have different services, syringe services for people who inject. And I still don't often hear a lot about how we're trying to rectify some of the harms that were caused by drug policies and mass incarceration for people who use substances that aren't opioids. And of course, if we have any medical professionals here, people who are familiar with the painkiller epidemic, we also know that historically individuals who are white are disproportionately believed about their pain and given access to painkillers more than others. So when it comes to sociocultural factors, we cannot, again, if you identify as that capital H, capital R, we cannot pretend that this doesn't exist, because it very much does. We can walk and chew gum at the same time. We are perfectly capable of doing it as a society. I know in Virginia, you have some rural areas there. There's a fascinating article I came across that said America is in the middle of 2 epidemics, but only looks at one. And it's the meth epidemic and it's the opioid epidemic. And it was a fascinating look at how even rural communities are being very much forgotten and pushed away. And then finally, with principles, it's pragmatic and realistic. Again, we do not inflate risk. We do not downplay it. We don't use fear. We don't use coercion. We simply state information as we know it to be. And we look at what the person is capable of doing and what they want to do and work within their own parameters that they tell us. This is not I think you could probably do more, so I'm going to blank. No, no, no. You tell me and I believe you at face value. And just to wrap up before we break for lunch, harm reduction is intersectional. It's not just about substances. So harm reduction has to look at racial equity, housing, sex work, our LGBT, transgender, non-conforming folks. It looks at reproductive justice, healthcare, it looks at decarceration, and of course, young folks who are often very vulnerable to different types of drug-related harms because they're under the insurance of their parents. They're often dependent for housing, things like that. So whenever we talk about harm reduction, it's not just drugs, it's looking at how it intersects with these different movements. And if you have an interest in any of these different populations, if you go to our website, you can click on each of these and it will take you to a resource that will kind of tell you about like different programs or organizations that are doing on the ground work with regards to kind of each of these in a very harm reduction way. So yeah. I think that this is probably a good place to pause. How's everybody doing? Get going. All right. Okay, so there were no concerns or anything like that on break. Wonderful. So if there's no questions about intersectional harm reduction, let's talk about some of the alliances. I knew about trauma-informed care before I came into the harm reduction world. I was very surprised though, as I got out of the harm reduction world and I went into the treatment side of things, how often folks, and this is just my experience, but how often folks were speaking about trauma-informed care, or they seem to be very kind of on board with a lot of trauma-informed trainings, things like that. The reality is that harm reduction is inherently trauma-informed. Trauma-informed care isn't inherently harm reduction. You can see though that the principles, the trauma-informed care principles, align almost perfectly with the ones in harm reduction. It really isn't asking you to do anything different. They're very similar. I want you to keep in mind why it might be more, why folks might be more motivated to look at trauma-informed care versus harm reduction. With motivational interviewing, if there's anyone here who has even a base knowledge of motivational interviewing, you're probably familiar with this spirit. And that is a huge part of how to authentically keep in line with the motivations of motivational interviewing from the creators. One of the big things that Bill Miller and Steve Rolnick. Oh my gosh, I always mix up their names. I feel terrible. They always talk about the importance of the spirit. Without the spirit behind motivational interviewing, they're very clear in saying it's essentially hocus pocus and it's a way to manipulate people. You have to have that spirit. You have to have an unconditional positive regard for people. You have to acknowledge that they are the primary drivers of change in their lives. And when I looked at the different aspects of motivational interviewing, again, it lines up very well with a lot of our principles. It's also that path to continuous engagement. No matter what stage of change somebody is in, there are harm reduction strategies that can be implemented. It's also, I always like to remind people, if somebody's not achieving a goal, it might be because they're actually in different stages of change. So for example, if somebody wants to stop using they want to stop using opioids, that's great. And they might be in pre-contemplation for smoking cigarettes, and their mind has kind of paired the two things, which is not uncommon. So it might be really hard for them to stop doing one while, continuing on with the other behavior. We also know that people can be action-oriented for some things. People can be in pre-contemplation for others. People can be in contemplation for a third behavior. But there are different strategies that we can offer everybody at whatever stage they're in. Please keep in mind too that harm, it's subjective. Harm is not a universally agreed upon thing. It's kind of like trauma. What I consider to be a trauma, somebody else might not, and that's okay. It can be wildly subjective. So it also depends on a lot of different things too. The experience of trusted peer groups, assumptions from providers, things like that. So a good example of that might be one thing that used to be really unfortunate is the treatment facilities around my area. A couple of them, the ones that were easiest to get people into, had very rigid policies around food. So if there was a treatment coordinator who, was like, okay, we're going to get this person into treatment. This is great. They've navigated all these other resources. They're set up for success. Fantastic. And doesn't actually sit down with that person and explain to them what's going to be expected of them, the different rules and regulations that they're going to have to abide by, and really have those hard conversations. We can be setting them up for a situation where they are discharged, and this absolutely has happened, for eating bread because they're hungry. And I don't think I have to remind anybody here that when people grow up with extreme poverty, food insecurity, anything like that, restricting food can be extremely detrimental. And it can really be setting somebody up for failure. All the policies in the world are not going to change human behavior, especially when there's that rapid shift from I'm outside to inside and have to change immediately in order to abide by these abstract policies. We would call that harm displacement. So I'm trying to decrease harm in one area. Meanwhile, I'm actually creating it in a different area. I would sometimes think back to folks that we would try and get housed. So they would be on a housing list waiting for someplace to open up. And a lot of people would say, I don't want to go into the shelters. I'll be on the street. And it would be like, no, but the street is so dangerous. And, if you could just get into a shelter, and then we can get you into a home. And over time, people had kind of bought into this idea that there was an expectation that they should want to be housed without actually thinking about what that's going to look like for them. So what could happen is, on the best intentions of providers and coordinators, we would try and get them into a shelter. The shelters around here, can't speak for yours, but the shelters around here, when I actually started to go to them, I would prefer being on the street. They were overcrowded. It was chaotic. It was stressful. And some people they felt genuinely a lot safer on the street. And then getting them into a house, it was the first time maybe they'd been away from their community, or now they were separated from a pet because there was a policy that didn't allow it, or now everything's quiet, or now they have something to lose. They knew how to navigate survival. They knew how to be on the street. They knew how to do all that. But what happens when they now have something to lose? That self-fulfilling prophecy, that internalized stigma that we're going to talk about, that's real. And we, as providers, did not do enough to prep that individual and set them up for success. We just made a whole lot of assumptions about their resilience. And finally, here are some other forms of harm reduction. There's a lot of them. It's not just about drugs. We can also look at this from a frame of little h, little r as well. That's perfectly okay. I remember when I first went to the clinic that I used to work at, and they had a very big DBT program, so dialectical behavioral therapy. I almost fell out of my chair when I said, wait a second, half of this is harm reduction. You can call it whatever you want. You can call it distress tolerance or crisis survival. You can call it whatever you want. But at the end of the day, it still is a harm reduction technique. So for example, if somebody was self-harming by harming their skin with a razor, there might be a strategy to hold ice. There is still very real harm that can be caused by putting ice on skin and holding it. However, is that harm less than what might be incurred had they been harming their flesh? Absolutely. It is a form of harm reduction. Might not be called that, but it is. So there's lots of different things here. The other one that I thought was a really beautiful example, I saw this a while back. It was tractor trailers, Samsung tractor trailers had noticed that there was a lot of fatal car collisions that were happening when people were driving behind a tractor trailer, because they have to go the speed limit. And then people would try and get in front of that by speeding up, but they couldn't see who was coming on the other side of the lane. So they would have head-on collisions. So what they decided to do was they outfit the back of their tractor trailers with LED screens so that you could see what was happening in the lane in front of you. And I thought, what an interesting, that's harm reduction. We quote, shouldn't be breaking the speed limit. We quote, shouldn't be passing by tractor trailers, and yet people do. So how can we help people not die? And it was just a very simple thing that I thought was really kind of brilliant. And that kind of takes us into our section on stigma, which I kind of just gave away. If we're okay with some of those other techniques, some of them are a little bit more controversial. Maybe not everybody's on board with PrEP. Maybe not everybody's on board with condoms or, medications for opioid use disorder. A lot of them, though, people do universally kind of rally around. And if we're okay with those different types of strategies, why are we not always okay with syringe service programs and things like that that are geared towards people who use drugs, people who engage in sex work? And a lot of that comes down to stigma. Harm reduction, it doesn't ask you as a provider, an ally, anybody to do anything that you're not already doing. We're just asking you to apply those principles equitably. We're asking you to walk the walk, not just when it's convenient. There's no such thing as a perfectly worthy person of help. So if we're going to try and strategize and offer some harm reduction strategies for a person who's in a domestic violence situation, why is that person? Why is it okay to kind of strategize around that, but not somebody who's injecting substances? And a lot of it comes down to stigma. I had, and kind of to speak to the point at the end, I often hear in trainings to be non-judgmental. And I have some bad news for everybody. Human beings, we're judgmental. We have judgments, it happens. Now, there are positive judgments, there are negative judgments, and there are neutral judgments. But a judgment is essentially you're kind of looking at a situation and making decisions based on it. If you have any type of a position where you have to make assessments, you're making judgments, you're making judgment calls. So not all judgments are bad. The ones that are, though, it's important to not pretend that they're not happening. Instead of running away from them, please lean into them and examine where they're coming from. I had read a post a while ago, and it was a woman who was describing it. It was on social media. This is one of the good things social media gave me, so I'd like to share it with you. Might never happen again. But it was a really lovely post where a person was talking about how they were, I think they were in Walmart. And they said, I had this moment where I'm walking through Walmart and I see this person and they're wearing these clothes and they're just thinking, oh my God, who let you walk out of the house like that? What are you thinking? Don't you have a mirror? Oh Lord. And then immediately, oh my gosh, what am I thinking? That person's not hurting anybody. What is my problem? If that person feels good in those clothings, like right on. Who is really being harmed here? No, there's no harm happening. And a person responded to the post and said, my mother always taught me that your first reaction is a reaction that society has taught you to have. Your follow-up reaction, that's your opportunity to be the person you really want to be. That can be the reflection of who you really are. So if you have a judgment, name it, call it out, examine it. If we pretend that it's not happening, we can't grow. And nobody's perfect. Absolutely nobody's perfect. So to say that there's a person out there who is completely judgment-free, that's not possible. We're all affected by our experiences, by our own lenses, by our own cultural cognition. All those things come into play. So please, if you have a judgment, don't pretend that it's not there. Lean into it and examine it and use it as an opportunity for growth. And that brings us to stigma. So what is stigma? Ultimately, it literally means, going back all the way to ancient Greece, it literally means to call out people who were, quote, criminals or deviants so that people could be separated and openly shamed and punished. The interesting thing, though, about stigma is, and I want everyone to kind of reflect on this, research has shown that the more a characteristic is believed to be in somebody's control, the greater the stigma is associated with it. So if you are somebody who believes that people who use drugs, well, they're making a choice. They could stop. They just need to pull themselves up by the bootstraps. Like, this is their choice. There's going to be a whole lot of stigma there. If you look at somebody who has a mental health condition, let's say somebody with schizophrenia. Let's say you see somebody with schizophrenia and maybe they are on the street and maybe they're talking to themselves. If you're somebody who might have that background where you understand schizophrenia and think, oh gosh, that's a person who's maybe not stable on medication, maybe somebody who's going through a rough time, whatever it may be, you probably won't have, there's not going to be a lot of stigma associated with it. But if you're somebody who thinks, why aren't they on meds? They should be on meds. Well, what did they think was going to happen? The stigma is going to be really great. So if you think something's going to be in someone's control, that's often going to be kind of the degree to which you can anticipate stigma. One of the first things you can do to combat stigma, though, language. Truly and honestly, one of the best things you can do is language. Person first language whenever you can. Person first language, so a person who blank, a person who uses substances, a person who engages in sex work, a person with schizophrenia, a person with bipolar disorder. Anytime we can highlight the person as opposed to the behavior or the condition, it humanizes people. Humanizing people, it humanizes them. That said, be aware though of identity first language. So we tend to see identity first language and there's various reasons for this. So a really good example is the deaf community. I live near Rochester. We have a really big deaf community here. They identify as deaf. They are not a person. My cousin is not a person with hearing loss. They are deaf. That is their community. That's their culture. That's their identity. So that's identity first language. We see the same thing happening in the autism community. Some people very strongly identify as I am autistic, and some people might prefer, no, I am a person with autism. To kind of take it into the world that we're talking about now, there has definitely been a movement, and we've seen this with other folks with different conditions and behaviors, to kind of reclaim language. So it's not uncommon. I definitely have had people self-identify as I am a, I'm not comfortable using the word, but a junkie. I will never use that word. But some people have found empowerment in it. And if that's something that they found empowerment in, okay, my default is best practices. You are a person who uses drugs. It's important too to listen to how the person is using those words. There's a big difference between like, yeah, I'm a junkie and you know what, I'm going to do this. I'm going to take care of people and, versus, well, I'm just a junkie. So there's a difference. There's a difference in how that person is conceptualizing themselves. And this comes a lot with, rapport. If it makes sense, and if you have the rapport with somebody to explore language, it's never a bad thing. Is this a term that they're finding empowerment with or disempowerment? Same thing with addict. So it's not uncommon in certain recovery circles for people to kind of take on, I am an addict. And if that's something that you find empowerment in, great. If it's something that you find disempowering, let's explore how else you can talk about yourself. That might also threaten your standing in that specific community if there's an expectation, because the drug using community is its own distinct culture, just like recovery community. In fact, SAMHSA, for all of my little issues with SAMHSA, SAMHSA did do a really great job updating their treatment improving protocol. It's tip 59 on cultural competence to specifically talk about drug using culture and recovery culture, and they expanded military culture too. So yay, SAMHSA, you get one. So yeah, just kind of keep that in the back of your mind. There's person first language and of course, identity first language. Please don't ever pretend to be part of a community if you're not. And if you are somebody that uses identity first language to describe yourself and your experiences, just try and not make an assumption that other people in that community will do the same. Now, when it comes to stigma, you heard one of the folks on the video talk about the community being kept out, away, and kept down. Those are the functions of stigma. Stigma really seeks to differentiate people, to signal danger, and to discriminate. So when we're looking at how those kind of core elements of stigma, there's a lot of blame and moral judgment. There's criminalizing, pathologizing, patronizing, and then of course, fear and isolation. So if I'm looking at somebody, if I have the underlying belief that drug use is in a person's control, well, you have nobody to blame but yourself because you're a bad, selfish person. So because you're a bad, selfish person, I don't necessarily feel bad about locking you up because, and here's the pathologizing and patronizing, because you don't know how to take care of yourself because you're a bad person. So I'm going to put you in jail until you figure it out because I know what's best because I'm clearly more functioning than you are. And you're just a sick person who's probably always going to be sick. So we have to put you away. And that's that fear and isolation piece. Stigma, now there's been a lot of different research. So if you're somebody who does have a strong interest in stigma, I'm just gonna own it right out of the gate. There's many different ways that people, researchers, individuals, communities conceptualize stigma. This is kind of the best representation that took from a lot of different theories. So stigma is kind of an umbrella term for stereotypes, prejudice, and discrimination. So we have our ideas, our belief, and ultimately our actions. And what that looks like in the cycle, because this is really what I want to focus on. Let's talk about the stigma. So let's, for example, take a person who is a parent. Let's take a mother. Let's take me. I am a mother and I am a person who uses drugs. So the stigma might be mothers who are the providers for their children and use drugs. They are selfish and they don't care about their families. They only care about themselves. And ultimately, they're bad moms. The stereotype and label. You're a bad mom and you can't be trusted with your children because you're selfish. So what that ends up happening is it becomes internalized. And if you're going to treat me like a bad mom, if there's nothing I can do to change your mind, no matter what I try to do and better myself, if I'm always going to be a bad mom to you, I'm probably going to be a bad mom. I'm probably not going to seek out a lot of opportunities. And if I do, they're not going to be available to me because you ultimately just think I'm bad and I'm selfish. And now I'm going to act maybe bad and selfish. And it just reinforces that stigma. I like that idea. Could we please stop saying stigma, which most people don't, and say prejudice and discrimination? Absolutely. Because stigma is really kind of that overall umbrella term, right? And we talk about the prejudice, which is, do you believe this stigma, and your discrimination, which is ultimately your actions. What are you doing with that? Are you confronting the belief? And how is it actually playing out? And shame. Oh gosh, and shame. Yes, all of that. How you talk about this with your folks, you do it however you need to do it, because I can only speak from my experiences in communities, and I trust people in the communities to know what's best and what's going to land best for the folks you work with. So please, if you want to deviate from this and you want to use different language, the words aren't so important as the actual message. So if you find folks respond better to other wording, please do that. I mean, that's also harm reduction, right? You're taking kind of a term that maybe isn't, the most empowering, or maybe isn't going to be well understood, and you're finding an easier way to reduce confusion and highlight the important messages there. Yeah. So we're going to talk about a couple different forms, right? So let's look at when people are facing stigma, discrimination, prejudice from other people. So this is ultimately how I feel about you. Let's take this scenario. If something goes missing from my office, it had to have been one of my clients. So the stereotype there is, well, people who use drugs are thieves and they can't be trusted. And the prejudice is, I agree with that stereotype. I'm going to be suspicious of clients, and I don't believe that they can be honest. So how that plays out in actions might be, well, I might only lock up certain things in my office when certain clients are around, not all clients, but certain ones. I might ask for unnecessary toxing. I might do observed toxing because I think that they're just naturally going to try and cheat or something like that. I might withhold incentives. I actually had one person say, I don't know if I want to give them the gift card because they're just going to go out and get drugs with it. And I thought, well, God, I hope nobody else ever looks at what I do with my paycheck. I wouldn't want somebody auditing my behaviors, right? So we have to kind of look at, that whole picture, how we feel about other people. So what can you do? First, we have to kind of confront, where did this come from? When has it not been true? Because people do tend to, I'm sure you're familiar with the algorithm, right? Cultural cognition, wanting to fit in with your own kind of chosen community and culture of most salience. People tend to want to seek out information that confirms that confirmation bias, that confirms what they want to be true. So we have to challenge ourselves and challenge our own internal algorithm almost. When has this not been true? and really lean into that. How has it been reinforced? What benefits do you get from this belief? Sometimes it's power. Who are you hurting with this belief? And, other things like that. So challenge yourself, but that has to start with being honest. And then we have self-stigma. So this is kind of that internalized, and sometimes this comes even from the best of intentions. And I really didn't think about this until somebody brought it to my attention. When I first kind of started kind of in the mental health field, the addiction is through the lens of the disease model was very popular. And I had said this to one of our participants, and they said, wait a second, so let me get this straight. So what I'm doing is a disease. Why? So I'm never going to get better. And I was like, no, that's not the case. And they're like, well, no, that's what you just said. If it's a disease and I'm always going to be like relapsing, what's the point? And I started to realize this could be really tricky if we don't explore it further, or we tie ourselves to a singular definition, because this could inadvertently otherize somebody. People can internalize this in a negative way. We can also fall into this trap if we don't understand a person's belief system. If we don't understand how they're conceptualizing their drug use, how they're conceptualizing their mental health, their own beliefs around diagnosing and Western medicine as it stands. We also have to look at, sometimes people are helped by this. Some people really like the relief of a medical diagnosis, or to know that something is a disease, because it feels less like I'm a bad person because I should just be able to stop this. Well, no, there could very well be a medical component to this. A heads up, many people in the harm reduction community do not subscribe solely to the disease model. There's many different thoughts in how this can play out. So I just want to kind of put that out there. If you are having a discussion with somebody who is kind of like a harm reductionist, I just ask that you're open to different interpretations of how this can play out, because there are many different people who use substances that do not necessarily rise to the level of having problematic use. And then, of course, when fear and stigma come into play, we never want people to have such a fear of the potential stigma or how they're going to be perceived by others that now they're kind of shying away from family and potentially losing out on positive supports because they're so afraid of how that's going to play out if they're honest. And they believe that there's no way their family could be accepting. There's no way their family's going to be supportive. It also might keep them away from educational opportunities. Like they might not want to come to the syringe service program. They might not want to engage in these conversations and be honest with what they're doing because of that fear of judgment. So we could also see a presentation of much of an escalation of behaviors. And I do want to highlight too, I just saw in the chat, there is compelling research that shows a large portion of people who use substances do not go on to develop a substance use disorder. I'm one of them. Did a lot of drugs for about 10 years of my life. But I would stop and I would start and I would stop and I would start, and there were different contexts. I always maintained a job. I was always, doing my thing. And then I just kind of stopped. There's some really interesting research about people kind of aging out around 35. Of course, that's not everybody, but it can happen. I also kind of like to think of it through the lens of, especially for treatment providers, I've definitely run into some people who don't think that that can happen. What's the saying? If you're a hammer, everything's a nail. If you're in a situation where all you're seeing are folks who have really escalated behaviors and are facing some really severe life concerns because of their use, that's not everybody. You're not seeing a whole bunch of individuals who do use and use responsibly, and it never really escalates. And some people just age out. I also went to college with a lot of them too. Yeah, a lot of them ended up being police officers. I find that very interesting. I don't know if anybody else noticed that. And then, of course, we have institutional stigma. So this is really your own organization, your own program. What are the attitudes and beliefs that you have about the folks that you're working with? Is there a very parental view? Is there kind of that patronizing view of, you might be familiar with white savior complex, right? We could also call it treatment savior, that whole, how that plays out. I am in this field because you need help and I know what's best for you. So I'm gonna do what I think is best because I've read the research and I went to school and I have the degree. So I'm going to set all this up because you don't know what you need. And if you did, you wouldn't be in this situation in the first place. Definitely seen programs constructed like that. So again, the more you can have the voices of the people who are being impacted by these policies and programs, the better. It's absolutely, oh yes, natural recovery. I should put that in there. Thank you, Tom. I will make sure I kind of credit that. And Todd, I will also credit you as well in there too. Thank you. Those are really important additions. So think about for your own program, if you want to implement a harm reduction approach when working with folks, think about how admission language looks. Think about the transparency, think about privacy, how easy it is to access. Think about how your own coworkers are behaving or your own work culture. Because if people have these biases or they have these really harmful prejudices and they're prone to discriminatory behavior, and that's sanctioned or overlooked by your higher ups, that's going to create a very toxic work environment that will absolutely influence the practices of people who utilize your services. And then of course we have, through association. So this might be a parent who has a child who's using substances. And well, if anyone finds out my son's using, they're going to think I'm a bad parent. They're going to think I did too much for them. They're going to think I didn't do enough. I coddled them or I neglected them. If I let them keep living with me, they're going to think I'm enabling them. And I do think that this is a good point to kind of highlight. Harm reduction is not anything goes. So again, we don't minimize that there are real harms associated with drug use. And because of the different things that can be involved in drug use, there are absolutely times where people can be harming others. So my general recommendation to parents, every once in a while I would have parents say, well, it's so easy for you to have this harm reduction mentality, but what happens when, it's your kid? It's a really good question. I'm a big believer in, first and foremost, you have to do what you need to do to protect your family unit. You have to do what you have to do to protect your family unit and your own mental health and your own sanity and your own relationships and keep that unit strong. And that's why I'm so grateful that we have programs like ours so that your child doesn't get completely lost, so that your child is still being fed, your child is still being clothed. And if something happens, we're going to be there to refer. We'll make sure that they're there to treatment. We can kind of pick up some of that slack that right now you're not capable of doing. When it comes to parenting, if there's a parent who uses substances and they lose, custody of their children or there's neglect, we're still mandated reporters. We don't let that slide. I do, however, want to look at what else is happening in that family unit. What lack of resources do they have? Is it a lack of money? Is it a lack of education? They can't get a stable job. Is there some way we can get them fast tracked on a medication? What's the holdup? Sometimes there are little loopholes here anyway. Sometimes there are little loopholes where there's little loopholes where especially if somebody is like a sole care provider or something, and there's a risk of a child being removed, because we know that typically children do better in their biological or in that natural setting versus being taken out. So we do a lot of advocacy where can we get them pushed through on medication? Can we get them set up with parenting resources? Can we try and encourage, maybe it's family therapy to try and reconnect some of those bonds. Maybe we can try and reach out to other family members that could potentially take temporary custody, offer some education for that person so they don't feel like their parental rights are being stripped. So we're always kind of looking out for, no, there's real harm that can happen because of this. And how do we still try and preserve everybody's dignity and safety? Sometimes it gets a little messy. But there have definitely also, if I'm being honest, there have been times where I've made a call because I knew that there was abuse happening and I don't regret it. I don't regret it at all. Because there was somebody who had no choice in this situation that was being harmed. Yeah, but ultimately my lens is I always try and look at this through what else is missing in this person's life that might reduce some of the behaviors that they're presenting with. It's not always pretty, but that's what I try and do. I like that parental tip. I accept it, but I don't have to like it. Yeah, absolutely. Absolutely. Let's see. Yeah, so this can look a lot of different ways. So if you are facing stigma through association, how do you cope? Well, first and foremost, education. A lot can be mitigated by just having some basic education. Expand your social networks, accept that maybe this kind of is how it is, that radical acceptance. Interestingly enough, with stigma by association, I sometimes feel this, and I'm always kind of clocking it when it happens because of my proximity to the drug using community. So I have absolutely had people say some very colorful things to me. How could you do this? How do you sleep at night? I hope your child overdoses. Yeah, all those different things. And I have to recognize that those thoughts and feelings, as hurtful as they were when I first heard them, are not often really being directed at me. It's often a reflection of the intense frustration, anger, and grief that people are struggling with, and I am the face in front of them. It's not fun, but I am sure I am not the only person on this call right now who has had to deal with people who have misplaced frustration, anger, and grief. Find some adaptive coping strategies. There's a lot of different ways to cope. And all of this really is aiming towards working towards that virtuous cycle, that climate of trust. We're trying to break that cycle of stigma and go to that virtuous cycle. So we're looking at developing better linkages, creating a climate of trust in our systems. And this is how we rebuild. It doesn't happen overnight. It might take a really long time, but the more you stay the course, the better the long-term outcomes can be. Just stay the course. And I know that there's a few folks on this call who are embedded in these systems. Please don't shy away. Silence is complicity. If you hear people saying things that are not okay, if you see people engaging in discriminatory actions, please, please say something. Stand up, say something, because this is ultimately how we influence change. We create change. And ultimately that cultural safety for people, which will lead to those positive outcomes, not only for people who use drugs, but the greater community at whole. So let's wrap up a little bit with some of these best practices. Be mindful of your body language and your tone of voice. I'm an animated person. You have to read the room a little bit sometimes. So especially if it's a serious situation or I have to deliver serious information, I will make sure that my voice comes down a little bit. I speak a little bit slower. My tone of voice is a little bit more neutral. It's a different interaction with a person. Match their energy to the extent that you can, and it makes sense. Always be mindful of your tone of voice. Asking permission. Would it be okay with you if I? How do you feel if we? Things like that, instead of just kind of taking over a situation and saying, here's what we're going to do. Be transparent. Be open about what you can do. Be open about what you can't do. Be open about your policies and things like that, and make sure people understand them. I am a huge proponent of health literacy. We know that the average person reads at a 7th grade level. Trying to navigate medical jargon, trying to navigate treatment jargon, all those different things can be really overwhelming for some folks. And also, health literacy is not just, can you read? It's, can you listen? Can you speak? Can you understand? Can you navigate numbers? There's a lot that goes into it. So just be transparent, make sure people really understand their rights, go over it with them. If people are signing off on things, I'm a strong believer in you should always know what you're signing off on. And if you don't know, ask somebody and have them explain it to you. Take grievances seriously. I had a person once who came into my office who was clearly, I had known them a little bit, and I could tell they were clearly in a bad way. They had been struggling with an abscess that was not getting resolved. When they came to see me, they were flushed, they were sweating, they were having difficulty breathing, there were red streaks. This is bad, right? This is a crisis situation. So I said to them, and I never would play the, emergency room card unless it was a real emergency. So I said, I got to tell you, I don't really have a lot to offer you right now. This is something that I really think needs to be taken care of by a medical professional. Do you think we can maybe get a Medicab and we can get you to the emergency room? And they had a visceral reaction, borderline panic attack. And after I kind of gotten them to come down a little bit, I said, okay, can you tell me what happened? What's going on? And they on to tell me about how last time they had to go to the emergency room, there was a nurse there that had to take their blood. And this person happened to know their mother. And when they were going to take their blood, they rolled up their sleeve and looked at those track marks and goes, wow, your mom must be real proud of you. And I had, I scrambled and I was like, okay, holy wow. Okay. And what can I do we'll go to a different place. I'm going to call ahead. I'm going to have you talk to them so you feel comfortable and so on. So as I'm debriefing this later, a friend of mine who was working in the program, she was actually in nursing school. So I'm telling her what happened. And she says, are you sure that's what happened? I don't know. That sounds a little, are you sure that's what happened? And for a second, I almost bought into it because this is my friend. And I felt like I was kind of insulting her profession. I don't know. I just had some feelings about it. I was still a little green. And it hit me like a ton of bricks. And I said, I don't know that it really matters if that was the exact wording that happened. What I know is that this person had such a terrible experience and felt so shamed that I was telling them that they could die and they did not still want to go get treatment. What would have to happen to somebody for them to have that kind of a reaction? And I've seen some people in all different types of professions do some really awful things because they thought maybe if I just shame people enough, they'll change. That's not how that works. Try not to take anything personally. A lot of these are, pretty standard. Please remember progress is slow. A lot of times people will come to treatment or for services and they have very deeply ingrained survival-based behaviors. Those behaviors do not go away overnight. So if a behavior has served a survival purpose, it can take a really long time for those behaviors to kind of dull down. Also, just kind of be careful with phrases like, I know exactly how you're feeling, or yeah, I know what I know, I've been in your shoes, man. This can be tricky. For some folks, it can be helpful. And I trust people know, especially with peers, I trust that those peers know the folks that they're working with. I do ask though that people be a little cautious with this phrase though, because it can feel invalidating. I'm one of those people where if you tell me I know exactly how you feel, I'm gonna be like, no, you don't, because you're not me. I don't find comfort in that phrase. And I know a few other folks, they don't really either. Some folks do though. One peer actually told me their preferred way of talking about it was, I haven't been in your shoes, but I have been in the same shoe store. And that always really resonated with me. Because again, people can use the same substance, and my experience if I were somebody who used opioids, my experience using opioids because of my privilege, my race, my gender, whatever, is going to be very different than a Hispanic male who's injecting meth and might be the sole provider for a family. So we might both be using substances, we might both be injecting, but our experiences are going to be very different. And always, always, always practice cultural humility. Be curious, but in a compassionate way. These are not individuals that we gawk at. They're not responsible for our own education. If we're asking questions, always be asking yourself, what is the reason for me asking? Is there clinical relevance? Is there a relevance to building rapport? Or is this just to satiate my curiosity? And if it's just to satiate your curiosity, not the time to ask. And that's it. That's our time together. Came down to the wire, but you folks are amazing. How is everybody? Anyone have any thoughts, comments? Thoughts, comments, curse words? We're all friends now.
No, all I just want to say is thank
Oh, you muted yourself. Oh.
Didn't mean to do that. I just wanted to say thank you.
Yeah, thanks.
This is really important.
A lot of really good, really important, timely information. Thank you.
Yeah, of course. Well, I want to be mindful of everybody's time. You have my information. I'll just throw it up here once more. Don't mind all of my tabs. Oh, I'm only down to 2. That's a good thing for me. Look at me. Woo, adulting. If anybody needs anything, please don't hesitate to reach out. Truly and honestly, you folks are amazing. Go raise some hell, change the world. Keep doing what you're doing. I know it might be a difficult environment right now, but it means a lot for you to spend this time during your busy schedules.
And Shannon will be joining us again on the second Thursday of August, 11 to 1, for our regular meeting time. She's going to be talking about motivational interviewing with people who use drugs. And she said she can talk about motivational interviewing all day, every day. And I think that if you've been, a clinician trained in motivational interviewing, you're going to maybe get something different with Shannon, really kind of looking at the spirit of motivational interviewing and how these harm reduction principles are integrated in a way that is maybe a little different. So hope you can join us. We'll put the video up on the coalition's YouTube page, and we'll be sending that link out to everybody shortly.
And if you don't believe me about the motivational interviewing, we're going to get to play with the values card sort. So yeah, it's the most undervalued part of motivational interviewing, but we are going to play. So please join. Well, thanks so much for